from 2013 to 2019.
Cool, thank you. Yeah, so as sorry, what's your name, sorry? Jacqueline, yeah. As Jacqueline said, I work within NHS England, but more specifically within the New Hospitals Programme, in the analytics team supporting the demand and capacity modelling, so I work quite a lot with the strategy unit. So in terms of the purpose, or like the introduction to this, there's been a perennial desire to avoid unnecessary hospital activity because of kind of obvious issues in terms of you don't want to waste money, you want to make sure the hospital is as efficient as possible, and you want to kind of improve patient outcomes. So there have been a range of initiatives to alleviate hospital activity over the past 15 years, such as the quality improvement, productivity and prevention, the Better Care Fund, etc. But there's been little understanding of their collective efficacy. So there have been studies into the specific policies, but just in terms of like a meta-analysis of all of the policies. And this is, because, as I said, I work in the New Hospitals Programme, so this is of particular interest in the New Hospitals Programme because we're rolling out a kind of centralised demand and capacity model to I think there's about 28 schemes at the moment. And it's like very important that these are built to the correct size. And obviously, each of those schemes will have their own activity mitigation ideas that they're going to be making assumptions about. So this provides a kind of evidence base to support the assumptions about the future. So yeah, that's the aim of this study. So there were three mitigation, this says 4 mitigation types, but that's including a counterfactual. So there were 3 broad mitigation policies that we identified. So the first one was redirection and substitution. So that's, say, redirecting activity to out of hospital to the community, for example, or substituting substituting interventions for alternative interventions which had less, like acuity, for example. There were also, the other one is prevention, which includes things like public health measures, so like anti-smoking campaigns or anti-drinking campaigns. And then there's de-adoption, which is about essentially, largely it's interventions or activity which we would consider to have limited evidence. And then the final one is the not mitigatable, which is essentially a catch-all term. So the way that this was identified in the data was essentially we essentially looked at activity that could have been within the scope of these mitigators. So, for example, for redirection and substitution, that included things like ambulatory care-sensitive admissions or mental health admissions via ED. For prevention cases, it's things like alcohol-related admissions, obesity-related admissions, etc. And then for de-adoption, as I said, it's interventions of limited evidence and things like follow-up outpatient attendances. And then the not mitigatable is essentially everything else. So it's quite important to note that we're not, for example, we're not saying that all follow-up outpatient attendances would be de-adopted, but we're just saying that some of them would be in scope of being de-adopted. So, for example, an intervention of limited evidence might be a tonsillectomy, like a routine tonsillectomy, and then we would expect that from alcohol, if we've got anti-drinking campaigns, that you might have a reduction in the incidence of alcohol-related admissions. So this chart is essentially showing the total amount of activity in the baseline year of 2013 by how it falls into those 4 kind of groups of activity. How the activity falls into those four cohorts. So we can see that the majority are falling into de-adoption, which is not surprising because that's including all follow-up outpatient attendances. Then most of the remainder is falling into not mitigatable, with a minority going into redirection and substitution, and then a small minority going into prevention cases. So in terms of the way that we actually did the analysis, so essentially what we did was we kind of calculated something called the non-demographic growth rates for those 4 different activity cohorts. So we were looking at the growth, their growth over and above that which could be predicted by increase in the population size and changes in its age-sex structure. So, for example, you would expect an older population over time to have higher rates of hospital admissions. And the crucial thing was, our theory was that if the mitigation policies were successful, then you would expect that their growth rates would be lower than the growth rates observed for non-mitigatable activity. So essentially, the non-mitigatable activity was our best attempt at providing a counterfactual for what would have happened without the policies. And obviously, there were limitations to that, which I'll get to later. So in terms of the results, in this chart, we've got, and I forgot to mention, we've stratified by 4 points of delivery. So there were elective inpatient admissions, emergency department attendances, non-elective inpatient admissions, and outpatient attendances. So on this chart, we've got those, the 4 types of activity and the 4 points of delivery, and then on the y-axis, the growth rates. So the first growth rates that we can look at is for non-mitigatable activity. So you can see about 0.67, 0.81, it's very close to 0 for non-elective and very high for outpatient attendances. So when we're looking at the next one, it's essentially showing you the growth rate relative to, this is just showing you the growth rate for that activity, but the crucial thing is that our kind of hypothesis is that the growth rates would be lower. So you can see for prevention cases and elective admissions and non-elective inpatient admissions that they're actually higher than the non-mitigatable activity. Then for de-adoption, you can see in both cases that it's lower, with the elective inpatient de-adoption cases actually having a negative growth rate. The outpatient still having a positive, but it's significantly lower than the 4.65 that for the non-mitigatable activity. And then finally, for the redirection and substitution cases, you can see that it is lower in emergency department attendances, but then for non-elective admissions, it's significantly higher than either the prevention admissions or the non-mitigatable admissions. So in terms of the key findings, we can see, this is kind of just a reiteration. So the key things were the redirection and substitution were higher. So for non-elective, it was 4.52% higher than the non-mitigatable. Then for prevention was also higher, so by 1.4% for elective and 1.5% for non-elective. But the adoption was indeed lower, as we would have hoped. For elective, it was 2.6% lower, and then for outpatient attendance, 2.7% lower. So in terms of the potential explanations for this, there were 4 mutually non-exclusive hypotheses that we arrived at. So the first one was essentially, as I said, we were using the counterfactual we were using was non-mitigatable activity, but we don't actually know what the growth rate, for example, for the alcohol-related admissions, we don't actually know that what the growth rate would have been without anti-drinking campaigns. It might be that it was even higher. It was just in the case of this study, the best counterfactual we could use for expediency was the non-mitigatable. The second is essentially the idea is that the de-adoption might have shown lower growth rates because due to it being easier to implement via defunding at the commissioning process, whereas for the prevention and redirection substitution cases, the idea was that essentially they're harder to implement because for example, if we're talking about redirecting to out-of-hospital settings, it's relying on the provision of those settings. And for example, prevention cases are relying on the provision of those kind of public health campaigns. And then finally, it's essentially a failure of theory. So that would just be that the policies were not designed properly, so they were literally just being counterproductive. So in terms of the conclusions, the key conclusion is essentially that, the results were counterintuitive to what we would have expected. However, there are some limitations to the analysis. So we were just essentially looking at activity that could have been, we were just looking at the growth rates for activity that was in scope of the mitigators, but not actually identifying the action of the mitigators within the data. And we weren't identifying the fidelity or the dose of the policies. Also, there might be confounding factors outside of the changes in the age-sex structure and size of the population. And then also, this is just a population-level analysis. So I think the main conclusion is that basically it suggests the need for a more kind of critical examination of mitigation policies, and particularly in the case of when we're making assumptions in the NHP, like when schemes are making assumptions for the sizing of their new hospitals, they need to be kind of more critical about the kind of extent to which that these could be changed into the future. And also, I think to address some of those limitations, it would be helpful to do more like further analysis, which might address those essentially. Thank you.
Thanks very much. Has anybody got any questions for Gabriel?
Thanks. I was really interested. I appreciate you talking about meta-analysis here of policy. But if your goal ultimately is for informing the demand and capacity model, would it be fair to suggest that demand is always going to rise? So regardless of what you mitigate, the demand isn't going to be capped. Demand will always fill. So really your rate limiting thing is capacity. So I guess my question is demand mitigation ever really going to work, or will demand always rise to fill?
Yeah, well, I think, yes, you would expect it to always rise, but I guess in this case, it's the fact that it's rising more than the non-mitigatable activity, which is what's more surprising than, so for example, the follow-up, the adoption in outpatient attendances, that was still showing quite a high growth rate. But I think it was more just surprising that it was showing a higher growth rate than even just all the other kind of types of outpatient attendance. Yeah, thanks.